show, and we've just shared the documentary on NCDs, the silent killer. Look, it's quite clear that there's a need for a nationwide effort just to survive this hidden enemy. I think we've got the three best people to help us understand the size and scope of the problem and how to solve it. Joining us for this conversation, Professor Gordon Abekah-Nkrumah is a senior lecturer of public administration and health services management at the University of Ghana Business School. He's joining us over the phone alongside Dr. Eric Nshiah-Boateng, who is in charge of monitoring and evaluation at the Ministry of Health. And joining us via Zoom is the Director General of the National Health Insurance Authority, Dr. Da-Costa Aboagye. Good morning, Docs and Prof.
Good morning.
Thank you so much for making the time. Now, I think I'm going to go through this with you one by one, starting with Professor Abekah-Nkrumah. So let's talk about the financial burden of these non-communicable diseases. How serious is the burden on patients, on the healthcare system, and on Ghana's economy?
Thank you very much, Kudo, and good morning to you and your listeners. So, when we talk about NCDs in general, it's over a big, if you like, space. But I think that on this documentary, I think the focus is being on, based on what I talked about, was on hypertension. And that seems, hypertension and diabetes seems to be the most common NCD. So maybe we can just pick one of them and look at its effects and try to, if you like, simulate it from there. So, for instance, if you take hypertension, okay, there are studies that suggest that hypertension incidence in the general population is about 30.3%, and you can look at it in the context of the uncertainty. So it ranges from a confidence interval of about 26.1 to about 34.8. So what it means is that the prevalence could go to about 34.8, approximately 35%. And if you look at the cost of treatment, so when you talk about cost of treatment, you can look at it from about three sides. You can talk about direct cost of treatment from the side of the patient, and then you can talk about the cost of treatment from the side of the state, because remember that in Ghana, healthcare is highly subsidized by the state. And then you can talk about the cost of treatment in terms of opportunity cost. Opportunity cost here means time lost to productive activities based on disability. So you can look at treatment cost in these three dimensions. But first of all, let's focus on the direct treatment cost. That is the one absorbed by the patient.
Right.
There are recent studies that for Ghana that suggest that monthly cost of treatment for diagnosed patients is in the neighborhood of around 5 million USD per month, about 5 million USD per month. And if you sort of pull the uncertainty within this treatment range using the prevalence of 30.3, which ranges from 26 to about 35, it may move to around 4.3 million to about 5.7 million a month in terms of overall cost of treatment for those who have the prevalence. And the ironic thing is that, hypertension can lead to a whole lot of things, okay, when there are complications. For instance, kidney failure. It can lead to heart failure. It can lead to things like myocardial infections. And kidney failure seems to be the biggest complication that arises from hypertension. And the estimate shows that about 71% of the cost that we are talking about is related to kidney failure. And think about it, that kidney failure is used not to be on the NHIS until recently when it was added, it will mean some huge cost, okay, to patients. And so, Kojo, what I've just given you is basically direct cost of treatment. Before you can then talk about the cost on the state, in terms of, remember that in Ghana, the state finances mostly everything from fixed assets that goes as input into the healthcare production process.
Right.
The state finances everything about salary. The state even finances part of the cost of medications. And by the way, the estimates that I've given you, they are based on cost of medications based on the NHIS list. And we know that the NHIS list is basically, the medications are mostly generic. And in actual practice, there are some people that might deal with medications that are not on the NHIS list. So it tells you that even the direct cost could be very, very expensive and over and above the estimates that I've given you based on what we see in the literature. Before you come to what the state then puts in based on the parameters that I've already cataloged. Before you then talk about estimates of the opportunity cost. So, for instance, somebody has hypertension with complications from kidney disease or heart failure. What it means is that the ability to work is reduced drastically. The time that they put into production activities is also reduced. That is also additional cost. So if you pull these three sets of costs together, it tells you that the cost implications of hypertension alone is incredible. And so if you then follow it to other NCDs, I would just presume that the cost on individuals and the state can be your guess. Thank you very much.
Thank you, Prof. Now, Dr. Nsiah-Boateng, I am aware of an NCD prevention and control program under the Ministry of Health. Tell us about it. Exactly how well resourced is it?
Yes, thank you very much, Kojo, and then good morning to your listeners. I'm happy the Director General is also on this program, and respectfully, maybe I'll leave this discussion, that section to him, and then I will focus on the policy aspect of this whole discussion. You are right, we have that program, but what I can say is that as we speak, we have the national policy on the NCDs, which the recent one, which is the 2022. It was launched in March 2022. Before that, we had an NCD policy and strategy for the year 2013 to 2017. One big challenge, which I would say from the policy level that we've not been able to do, especially with this particular strategy I just mentioned, has to do with funding. In fact, and that even informed the revision of it to the current one that I talk about, which is for starting from 2022. The funding has 2 points, if I may say so. One has to do with funding for the NCD-related activities, and here I'm talking about prevention and health promotion of risk reduction and treatment adherence. That is one arm of the funding challenge. We also couldn't find a lot of resources to also deal with prevention and control program of the NCDs. But having said this, I would like to say that the maiden one, the NCD policy, chalked a number of successes. And one of them is that it helped us to be able to promote the Public Health Act with a session on tobacco and control measures. The other successes that maybe we chalk at the policy arena will be the passage of the tobacco control regulations, that is LI 2247 of 2016. There are a number of them, for example, the inclusion of diabetes, hypertension, and road traffic injuries in Ghana's integrated service, disease surveillance and road response. So we may say that maybe funding was a challenge, but when it comes to coming out with policies and other legislative instruments to address some of the risk factors, the ministry or the sector was able to do a number of them.
Right.
The recent one, as I mentioned, is a new policy that we believe that we also have to make it a policy in terms of the funding, as one of the policies to look for funding from government, from donor communities, to be able to do some of the things that I've talked about. Apart from funding, another challenge that we also saw in the implementation of the previous policy, data, and we still have that challenge. We have weak data collection system for NCD. And in the morning, I was listening to you. You mentioned some of the prevalence of some of these diseases that we have in the country. These are estimates that we have. So data collection is also another challenge that we are also working on that to be able to come out with the accurate, prevalence of the condition,
right,
in terms of the cost burden to the family, cost burden to the individuals who are unfortunately going through this. So these are the issues that, Kojo, I think for now, I will mention it, and then as the discussion goes on,
sure.
I'll come.
Dr. Nsiah-Boateng, help us clarify something. You've talked about how one of the major issues is funding of the implementation of the policy. What would that funding have gone for? What is the money needed for? What are the specific initiatives under the policy that require funding?
Yes, in fact, there are two key issues that require funding. The first one, as I mentioned, was the NCD-related activities. And when you talk of NCD-related activities, you talk of fiscal, activities, some interventions that to promote healthy living and other things. It also goes into the medication, as we mentioned in the morning on your program. So typically, the prevention and health promotion of risk reduction and treatment adherence.
Okay.
That is one big arm.
Okay.
The other arm is the prevention and control program. You mentioned in your intro that we have the program within the sector. Funding is a key challenge for the staff over there who are working to promote and also advise Ghanaians about what to do to prevent some of these issues.
So on paper, what are the specific things, for example, under prevention and control? What does this say in the policy that Ghana is going to do about preventing and controlling NCDs?
There are a number of activities. I'm happy yourself and your team were discussing some of them. Fiscal activity is one of them. Prevention, as we all say, is better than cure. So the focus is on preventive activities and then promotive activities. We need to encourage the citizenry to, do a lot of physical activities, also eat well. You mentioned the issue of having the vegetables, and then we limit our consumption of carbohydrates and all those things. Eat a lot of fruits and all those things. These are the things that we believe that the attention has to focus. How do we, encourage the society? How do you encourage the population to make sure that they also include a lot of vegetables, include a lot of, fruits in whatever, food that they take? And then as much as possible, we cut down the intake of carbohydrates. So I think the focus is on preventive and promotive, activities that we believe will help us reduce the risk of NCD.
Before I bring in Dr. Da-Costa, you're asking the same questions on my mind. How do we encourage people to eat more fruits and vegetables? How do we encourage people to exercise more? What does it say in the policy? If the money were to come today, what would you use it to do? How would you go about encouraging people to eat more fruits and vegetables, for example?
Yes, I think this is something that the National NCD Control Program is well versed in. There are a number of the how to do activities, if you like, as to how to go about them. At the program level, they have the strategic intervention. They have the implementation plans to go about this. And I believe that when we are able at the sector, at the ministry level, to be able to mobilize the resource, the required funding for them, these implementation documents that they have as to how we should, encourage the population to embark on regular physical activities, and also make sure that the dietary, intake is more of the vegetables and then the food that we are all talking about. It's something that we have confidence in the program managers to be able to carry out.
All right.
And as I mentioned, I believe Dr. Aboagye will add a lot to that.
Okay, it's a good time to bring in Dr. Da-Costa Aboagye, who, of course, is the CEO of the National Health Insurance Authority. Dr. Aboagye, you are quite literally the biggest primary healthcare financing scheme in the country. And this is more than anything a money problem. How is the NHIA attacking NCDs?
Okay, good morning, and thank you for inviting me to your program. Let me say that it's a good program. I think let me address some things before I come to how the NHIS is actually will be supporting the NCD programs in terms of funding. I believe that the NCDs are the next pandemic, and we really need to take it serious and tackle it from the roots. And in doing this means that the gentleman that talked about obviously the promotive activities that are needed, obviously, to aid the population for a healthy living. From the NHIS point of view, we believe that for our 20-year history, it has been curative. So you wait for people to be sick before they go to the hospital. That is not right. So the new reforms coming in will be focusing on preventive healthcare using the biomedical approach. That is how we call it. So we will be introducing what we call the annual health check to detect these NCDs at the early stage. One, the benefits are that it will actually increase our life expectancy. It will reduce the cost burden on the NHIS itself, and it will also help us achieve the Sustainable Development Goals, especially the Goal 3, which talks about the wellness. So because I previously worked in the Ghana Health Service, I know that they are using the wellness. They have what we call the wellness clinics. So now all facilities are mandated to have what we call the wellness clinics. The wellness clinics is where people can go in to check their vitals and also to receive counseling in terms of good nutrition, good lifestyle advice, and others. But we believe that on your day of birth or on your month of birth, you will get a text message from the NHIA. The program has not started yet, but you will get a text message to go to the nearest health facility to check at least your sugar, to check your blood pressure, and to check your weight. That's your BMI. Because when we looked at the data, hypertension, diabetes are actually one of our major cost drivers, and we need to reduce this. But in going forward, we will try and also add other labs in terms of like HPV and the others, like pap smear test and all the others. So we want to start somewhere so that we learn from it and continue with it. We have all been talking about kidney diseases. In fact, the preventive approach is the best. And bear in mind that the NHIS also fund acute kidney disease. So the dialysis that we are talking about is at the end stage. So it is time for us to take, or for us to come to the basis and say that, no, let's address this head on, right from the preventive aspect. Then we will see that initially the cost may go high as we do that, but you see that the cost burden will obviously reduce over time. So this is the NHIS approach in terms of how to deal with it. But let me say that globally, we have what we call the health in all policies. The health in all policies also put responsibility on, for example, the Ministry of Youth and Sports to promote physical activities. So there must be health in sports. There must be health in, let's say, agric. So the food that we eat, the planting for food and jobs, what is the health component in it? Are we producing more vegetables, more fruits for our people?
Right. It would seem that we have a bit of interruption.
Hello, can you hear me?
Yes, Doc, we can hear you now. Please go ahead.
Can you hear me? Yeah. So, for example, I was talking about the Ministry of Agric in terms of their planting for food and jobs policy. Can we say that obviously they are empowering the farmers in such a way that they come up with more fruits? Then we come up with a policy like 5 a day.
Yeah.
Like, do you get, my line is actually not
Yes, there's a bit of interference.
I apologize. So those are the kind of thinking that we must be. Yes. So those are the things that we need to obviously come up with. And I believe that the need in the end, I'm happy that I was at the Ghana Health Service and I was part of those who developed these NCD policies. So I think in totality, all that I'm saying is that we must to address this from the basis. Funding is an issue. Yes, it is an issue. Apart from the vertical funding that comes in for the programs, there is no systemic funding for obviously the preventive health care. Right. So this is what the NHIS is trying to address.
Thank you for that. You mentioned the wellness centers, and I've always wondered about those. They are in the healthcare facilities, as you explained. But we all know that a big part of the problem is that our health-seeking habits as a people are not great. People don't like going to hospitals. So putting the wellness centers in the hospitals, is it not pretty much, putting them exactly where people don't go? Can the NHI think about perhaps having them in places that are more accessible to people so that they will take advantage of them easier?
In fact, you are absolutely right. So that is just one of the wellness components. So it's not entirely. So if you look at the Ottawa Charter in terms of the reorientation of health services towards prevention is better than cure. In fact, we want to make sure that the health service actually is in a holistic, gets its full totality of services. So that's reorienting of health services towards prevention is better than cure, as was proposed by the Ottawa Charter in 1978. It's actually has been operationalized in many countries. But bear in mind that in the hospitals, that is where we have the public health nurses. They go to the communities. They detect them. Then when they detect, they bring them to the facilities. So this is not to say that once the wellness clinics is in the facilities, the community interventions are ceased. No, they are not. It's a whole chain. So I get what you are saying, but I think it is also part of the wellness clinics, because the hospital, the public health nurses must be able to go to the communities to do education. The health promotion officers must be in the communities to do the education, so that we attract those who need the help to the hospital. But the wellness clinics concept, you see, you do not have to be sick. You do not have to be sick before you benefit from it. That is what to give us the early detection of the diseases. That's why I said it's the biomedical approach.
Yeah. Okay. Now, Doc, we've talked a lot about the prevention, which really, as you say, is the most sustainable approach. But of course, we still have huge numbers of people who have these non-communicable diseases, and we have to manage them. Now, what I've discovered through a project that I used to run here at Multimedia called the Sugar Project is that very often when we go into rural areas and we test people for diabetes and we find them to be diabetic, and they get that diagnosis from the healthcare professional, it is almost like a death sentence to them, because the cost of managing that condition is impossible for many of them. And if it turns out that they are perhaps a type 1 diabetes, patient, and they need insulin, then that's even more ridiculous, because they can't even find a refrigerator to keep the medication in. That is if they could afford the medication. So, Doc, on that level, looking at the wider problem of managing non-communicable diseases across the country in the more remote areas, what is the NHIA's plan there?
Okay, thank you. I think I perfectly agree with you. You see, bear in mind that the reason why I said diabetes and hypertension is that the NHIS actually funds diabetes, hypertension. Mm-hmm. But the fact of the matter is that when we met the provider said that the tariffs are too low. So if the tariffs are too low, then it means that they have some hindrance. And you see, our act also provides that the review of the tariffs should be yearly. So, for example, if you have escalating economic situation, there is nothing that you can do about it, because obviously we might have finished the review. So the NHIS is also proposing another level of intervention, which we will take to Parliament soon, that we believe that we have to have what we call the automatic price adjustment for our pharmaceutical products. Once you do that, then you set up what we call the National Tariff Review Committee. So when the conditions or the economic situation is obviously escalating, then the National Review Tariff Committee will meet and review the tariffs. Then when prices also come down, they will meet and come. By that, you are giving them a buffer. You are actually helping them not to obviously charge the patients. But there is also another level that we have actually started just last week. Now, the government e-pharmacy platform is also going to help a lot, because now when you go to the facilities and you are diagnosed, they tell you that the medications are not there. Go to this pharmacy to take it. Go to this pharmacy to take it. And you pay for it. So we are saying that all hospital pharmacists will be enrolled on the National e-Pharmacy platform. Then when you diagnose the patient, what you have to do, the pharmacist will have the responsibility to put the prescription on the e-pharmacy platform to the patient's locality, so that the patient will just go to their locality or their local pharmacy to take the medication. Under no circumstances will patients be charged for that, but it's work in progress. Or even these pharmacists can also deliver the medications because of the property addressing systems to the various homes. This is what we do outside the country. So I believe that these reforms are ongoing, but it will all come together to help the citizens, or to help ease some of these things that we are talking about. But I believe that, yes, we have to give the facilities the right cost of, obviously, the cost of the medicines, for example, insulin that you talked about. So let's work it out, and let's everyone support the NHIS and its new reforms to see how it will actually support citizens. But it's not going to happen, obviously, just overnight. It's just work in progress. And this also means that we really have to take, like I've already said, the prevention. You see, I listened to one of your speakers. He was saying prevention. And it is prevention. In fact, the UK spends over 40% of their budget on prevention. And they have localized it in their local GPs, their local pharmacies, their local community interventions, promotive, preventive. So I think it's the same system that we're trying to see how best it will help our citizens.
Right.
I also believe that we have implementation challenges because of our structural, the structure of the country. But we are obviously poised in making an impact and doing such things. So support us in doing it, my brothers.
All right. So last thing before I take the final word from Professor Abekah-Nkrumah. Dr. Nsiah-Boateng talked about this prevention and control program for NCDs, and the fact that there's an entire policy simply waiting for funding. Right. And you've given examples of how these policies look in other countries, the 5-a-day program in the UK and so forth. So, apart from the wellness programs which are under the NHIA, is there any plan to help with the actual financing of the policies implementation at the Ministry of Health?
Okay. Thank you. I think, again, you are spot on. There is actually, so in the Ghana Health Service, there's what we call the network of practice. And under the network of practice, we have secured some USAID funding to pilot some of these things that you are talking about. So how do we actually fund, let's say, education? If you are educating someone in the population, how do you fund it? You see, so we're going to try something within the network of practice and see how it will work. Once we get to know its entirety, then we look at it from the NHIS point of view. How can we also support? But I believe that a time has come that in the next phase of the NHIS, we
apologies for the interruption there, Dr. Da-Costa.
To be investing in hospitals. Sorry, again, that.
Yeah, please go ahead. Yeah.
That will reduce the cost of these NCDs. Am I back? Sorry.
Yes.
There was interruption. Yeah. Am I back?
Yes, you are.
Yes. So I was saying that in the next phase of the NHIS, I believe that we must be investing in something like hospital equipment, because you detect these NCDs by what? Through this equipment, and it will also reduce the cost for the patient, even if they are. But let me at this point say that there are a lot that the NHIS is doing that the population do not know, and we have a lot of responsibility. And that responsibility, unfortunately, lies within the remit of the Ghana Health Service, the FDA, and the other institutions. So we need a collaborative approach in addressing all these. Other than that, our primary aim is to fund in an equitable basis. So ideally, you will know that it is really, I will not say outside the scope, though we have a responsibility, but we do not have the expertise in terms of promoting some of these. So if you want the health promoters, it's Ghana Health Service.
Yeah.
You know what I mean?
Yeah.
So we need, I would say, an all society approach, basically, based on the health in all policies that we have.
Right. Thank you for that. Prof Abekah-Nkrumah, I kept you for last because I wanted you to hear the interventions proposed by Dr. Nsiah-Boateng and Dr. Da-Costa Aboagye, so you could give us, in your expert opinion, whether these will go long enough away to resolve or at least help us mitigate the effect of non-communicable diseases, or whether more is needed.
Thank you very much, Kojo, and once again, good morning to your listeners, and especially the two panelists. So, yes, I mean, based on the cost profile that I gave, we know that this is not sustainable. And so I'm happy to hear promotion and prevention as the way to go. But I think that the way we do the promotion and prevention optimally is probably the question that we need to ask and try and find, if you like, optimal answers to that sort of question. I think that oftentimes when we talk about anything health, and especially NCD, we decide to narrow our focus on the health sector. And I think that this is not a health sector issue. This is a national issue. And as Dr. Aboagye said, it is the next pandemic. Pandemics are not located to sectors. It's a national issue. So how do I see this? And what do I think will be the optimal way to go? I think we need to look at the profile. And I would look at it in three stages. The first one is those adults and young people who already have the disease and how we manage them. And then those in the middle are probably adults who may have a higher predisposition, and how do we manage them? And then the last one is young people, very young people like our kids in school. For me, they are the most important cohort, and I want to start from them. So when it comes to young people that we have to protect, so that over the next 30 years, we don't have an epidemic or a pandemic on our hands, we need to deal with that group. And NCDs are basically two things. It is lifestyle, and then it is nutrition. So when you take young people in school, there are two things. It's either they are coming from affluent homes, and so their lifestyle is not good enough, or they are coming from poor homes, and so their nutrition is also not good enough. I would say that within that cohort, the focus should be on Ministry of Education and then employment and welfare. Why do I say so? The Ministry of Education can begin to include in its syllabus issues about NCD and lifestyles and nutrition to be able to deal with this issue, so that kids at that age begin to understand this and the implications of modifying their lifestyle. And for those who nutrition is an issue, because Kojo, you see, there are kids who can be predisposed to NCDs because they have nutritional deficits at this young age. Their body systems will then readjust itself in such a way that over time they would begin to have NCD conditions. And there are a lot of studies that have shown that, especially studies that looked at pre and post World War II, where kids who had nutritional deficits had biological adjustment in terms of storing food, such that when they grew up, they became a lot more predisposed to NCDs. That can happen. So, for instance, I can see something like the one that they do in school, the school feeding program. Right. Can be a good way of ensuring that those who have nutritional deficits, the school feeding program is addressing that. And the syllabus is also addressing those kids who come from affluent homes and are focused on all these junk foods. Now, the one in the middle, we talked about exercise, we talked about vegetables, we talked about fruits. Kojo, we know that these days vegetables are out of reach of the average Ghanaian. Yeah. And even where it is available, it is not good quality vegetables because of the way they are grown, the chemicals. I'm asking myself, what prevents the Planting for Food and Jobs program from initiating a model that educates every average Ghanaian to plant basic vegetables in their home? I know that most homes don't have soil, but Kojo, if you come to my home, the big dispensing bottle for water dispensers, if you come to the back of my house, I just flush them, find soil, put in, and mix it with poultry droppings. And you can come and see lettuce, broccoli. You can come and see all of them at the back of my house. And I think that this can be done so that there can be easy and affordable access to vegetables. Right. And people will have vegetables that are of good quality. Right. We can look at it from this perspective, and it is not just the Ministry of Health. It can be Ministry of Agriculture as well. Then we can come to the last bit, which is what Dr. Da-Costa has emphasized a lot in terms of wellness clinic, going to church, and the NHIS also paying for their cost of care, which in any case is not cheap. So basically, I would want to see an all-sector approach and not what just the Ministry of Health is doing. Thank you.
Thank you for that, Prof. And thank all of you for your contributions to this conversation. We really appreciate it. Clearly, there's more for us to talk about in the coming days and weeks. Professor Gordon Abekah-Nkrumah is Professor of Public Administration and Health Service Management at the University of Ghana Business School. Dr. Eric Nsiah-Boateng is in charge of monitoring and evaluation at the Ministry of Health. And Dr. Da-Costa Aboagye is the CEO of the National Health Insurance Authority. And they've been talking to us about non-communicable diseases in the wake of our Hotline documentary, NCDs, the Silent Killer.